Good afternoon, everybody. Um, Thank you for this opportunity. I'll be presenting my study on comparison of oximetry with cardiac MRI for estimation of flows in BDG population. This from a tertiary care center in Trivandrum. So we know that univentricular hearts are palliated by stage palliation, the BDG followed by TCPC. So before the TCPC, most often patients undergo both cardiac cath and an imaging study. Cardiac cath is usually taken as the gold standard for estimation of flows. It is based on the fixed principle, but it has inherent assumptions like for one, the patient is assumed to be in a steady state, which is representative of his baseline. But under anesthesia, this might not be true. And oxygen consumption, which is the numerator in the equation, is usually taken from age-based charts. It's not calculated for each case separately. And there can be errors from the underlying lesion, which involves incomplete mixing or some streaming effects. And now coming to BDG physiology, applying the fix principle is even more challenging because there's no true mixed venous circulation. The IVC and the SVC are separate. And pulmonary blood flow is from the BDG, antegrade pulmonary blood flow and collaterals. And BDG physiology under positive pressure ventilation and general anesthesia is different. So under modality, as ma'am had described, phase contrast MRI is used for flow estimation, and it has been seen that for estimation of QP, QS in simple intracardiac shunts like ASD, VSD, it has good agreement with oximetry. However, in BDG population, the data between cardiac MRI and oximetry flow is limited. So we aim to study to come back cardiac catheterization derived estimates of pulmonary and systemic blood flows with measurements obtained using cardiac MRI. So this was a prospective observational study done between November 2018 to December 2020. We enrolled 30 BDG patients who had undergone cardiac MRI and cardiac cath. Patients with significant antegrade pulmonary blood flow, interrupted IVC, large collaterals, pulmonary vein stenosis, PH, severe AVVR, ventricular dysfunction, and other contraindications to cardiac MRI were excluded. So flow calculations of QP, QS, and QP, QS were taken from previously elaborated studies. And in cardiac MRI, flows were calculated across the SVC, RPA, LPA, IOTA, individual pulmonary veins and IVC, and QP was defined as total pulmonary vein flow. QS was defined as the total caval flow. So coming to the results, the mean age of population was 108 months, and the time at mean age at BDG surgery was 21 months. Baseline saturation was 81%. About 20% of the patients had preserved antegrade pulmonary blood flow. The time duration between cardiac MRI and cardiac catheterization was 130 days. So the baseline saturations in the SVC, IVC, and PAs were around 66. The pulmonary vein saturation was 97. Aortic saturation, baseline saturation was 81. The pressures across SVC and PA was around 11. The LVDP was 9.9 and aortic mean pressure was 69. The flow data from cardiac MRI, it was seen that the IVC flow was numerically higher than the BDG flows, and the right-sided lung flows were slightly higher than the left lung flows. Then we plotted the total pulmonary vein flow, which is indicated in green, against the SVC flow, that is the BDG flow, which is indicated in orange. And we could see that in most of the patients, the total pulmonary vein flow was much higher than the total SVC flow. This suggests the presence of collateral flow. So flow calculations, it was seen that the QP from the cardiac MRI was much higher than the QP by cath. And however, coming to QS, it is much lesser in CMR with regard to cardiac cath. There was no correlation between cath and CMR for QP or for QS. And calculating QP by QS by any formula in cardiac catheterization was much lower value than what was derived from MRI. So, and so the QP QS from MRI was much greater than the QP QS by cath, and there was no correlation between cath or CMR for QP QS. So then we divided the population into two based on an arbitrary chosen cutoff of 0.7 of CMR QPQS. We saw that patients with a CMR QPQS of more than 0.7, the number were 19. They were different only in terms of cath-derived QP and MRI-derived QP and the collateral flows, which was higher in the QPQS more than 0.7. In other parameters, they were similar. So coming to PVRI, the oximetry derived PVRI is much higher than that derived by combined CMR and cath formula. And oximetry in this population of 26, we had seen that 3 patients had a PVRI more than 3, while in the combined CMR cath group, it was just 1 patient who had a PVRI higher than 3. So in comparison to the previous studies, we also were in agreement with them. There was no correlation between cath and CMR for QP, QS or QP by QS. The PVRI from cath was much higher than PVR derived by CMR and cath combined formula. The study limitations are, this is a small sample size study from a single center. 30% of the patients had a bilateral Glenn shunt, and in 20% there was preserved antegrade pulmonary blood flow. So oximetry values could have been affected by the streaming and degree of mixing. 100% of the patients who had undergone cath were under GA. However, while doing cardiac MRI, only 43 of them received GA. There was a time delay of 130 days between the cardiac MRI and the cath. So maybe few more collaterals would have developed. And we didn't assess the intra-observer or inter-observer variability. So to conclude, QP from phase contrast MRI is higher than QP by cardiac cath, while the opposite is true for QS. And QPQS derived from phase contrast MRI is higher than QPQS by cath. There was no correlation between QP or QS or QP by QS between the two modalities. Cath-derived PVRI was an overestimate in comparison to PVRI from combined CMR and cath formula. Patients with CMR QPQS of more than 0.7 had significantly greater collateral flow in comparison to patients with QPQS less than 0.7. But in terms of other parameters, they did not differ significantly. Thank you.